next presentation, Dr. Bai from Henan Hospital is the neurointerventional from a group from Professor Jeremy. Okay, Professor Bai, thank you very much.
Okay. Okay, can you see my screen?
Yes, you want to make it bigger?
Okay, thank you.
Yeah.
Okay, and dear professors.
There we go. Yeah.
Good evening.
Perfect.
Okay. Yeah. It's my honor to give my brief introduction of my experience regarding the flow diverter used for giant carotid aneurysm. I'm a neurointervention radiologist as a team member in from Professor Jeremy's name. Yes, in our hospital, the perspective for the aneurysm treatment is shift from the coiling packing to a flow diverter. So I know this topic is just focused on giant aneurysm. So I only introduce for giant aneurysm. In China today, we have some options to choose, including the most commonly used flow diverter, the pipeline, and our homemade flow diverters. We named it tube bridge, which is kind of braided stent made in Shanghai. So the other type of flow diverter, thread or surpass or silk, are not available in China today. So the following is the time point of flow diverter use in our hospital. So from the 2013, we had the first case of the flow diverter. We used the tube bridge to treat a giant aneurysm. Till last year, October, the total more than 62 cases were treated by flow diverter. So including all types of aneurysm. Among which 212 are PET, and the other 15 are tube bridge. So this table is the demographic features of flow diverter treatment in our hospital. You can see among of these more than 200 cases, is only 44 cases with giant aneurysm, with the bigger size aneurysm. So the flow diverter efficacy and safety for intracranial giant aneurysm for us is still limited. I have known the statistics in the subgroup of intracranial giant aneurysm. So the follow-up database is referring to general aneurysm population. So in the patients treated with flow diverter, we have a imaging follow-up 3 to 31 months with median follow-up time 6 months. So the total occlusion rate is up to 72.2%. I believe with time going forward, the occlusion rate will be further improving. So we have to say the complication. So in our hospital, the morbidity and mortality rate is 1.9, including delayed rupture and death in 1, cerebral ischemia and permanent deficits in 2, brain parenchymal hemorrhage and death in 1, and delayed parent arterial occlusion in 1. So as for gross complication rate is 6.49%, among which 13 cases was found in, okay, excuse me, why? What happened?
Don't know. Yeah, start sharing again. You fell off the screen share. Okay.
Excuse me.
There you go. It's full screen.
Okay, thank you. Yeah.
Full screen.
So as for long-term follow-up, with median follow-up time is up to 16 months, we have we found 4 cases with complication, hemorrhagic event and ischemic event in 2 cases respectively. So this is the landmark multi-central prospective clinical research, just as Professor Lilink said. So it's a very well-known clinical trial. In this trial, the big size and the giant aneurysm were enrolled. So as a result, is quite satisfying. So as for the technical success rate is up to 99%. And a majority of this cohort achieved imaging follow-up. As for the occlusion rate, when 1 year and a half is up to, it is more than 70%. With 1 year is nearly up to 90%. This is this result inspires is quite promising. So as for the experience in our hospital, I give an example. Here is a giant aneurysm. I deployed a flow diverter and combined with some coils, just loose packing. 3 months post the procedure, revealed a majority of the sac are thrombosed. Just a small area adjacent to the neck remained open. You can see this giant aneurysm with flow diverter and a coiling and get a good outcome. So we have many cases to show the nice efficacy of the flow diverter. You can see this partially thrombosed aneurysm with coiling and the flow diverter deployment get a very good angiographic outcome. So as for the occlusion rate and occurrence, so from above the clinical trial is quite satisfying. And from the follow-up, you can see with time going, the occlusion rate is improving further. Okay, let me show some complication with live cases. So this is a giant aneurysm. Here is round-like structure. We performed a not bad curling and flow diverter deployment. However, a couple of hours later, the patient presented with is a severe headache. The CT scan revealed hemorrhage. And after that, we performed a recheck of angiography. We can see some clothes was packed to the dome. Some part of the aneurysm neck reopened. Okay, this is yes, the last case eventually passing away. So this case is a giant aneurysm with flow diverter with not a bad outcome with a follow-up 4 months post the procedure. We extend the flow diverter use to some other type of aneurysm, like you say. It looks like not a difficult case, but after the procedure, the patient suffered from parenchyma hematoma. We don't know why, but after that we performed decompression and evacuating the hematoma and stopped the medication of antiplatelet using, and eventually the patient got a well recovery. It's not a severe deficit. So as for the hemorrhage post-flow diverter deployment, the possible reason, including the following from the literature, most of the reasons are just discussed by Professor Lilik. The one is maybe the hemorrhage might be injury caused by the catheter or guide wire, or after the flow diverter, some hemodynamic alteration happens, or the aneurysm wall has some inflammatory reaction. For some cases, we speculate cerebral infarction and a subsequent hemorrhagic transformation. In addition, some reasons are hypertension associated or some antithrombus medication associated hemorrhage may be deserve our more attention. So apart from the hemorrhage post the flow diverter, the ischemic complication we found as well. One is this one is the instant thrombosis. Even the patient after the procedure underwent a regular aggressive antiplatelet medication, there is still a possibility to develop the instant thrombosis. Just like this one, he developed the occlusion of the parent artery 6 months of the procedure and get a stroke. For this young patient, we got a standalone flow diverter. So the aneurysm is closed. However, the follow-up imaging showed us instant stenosis, very severe, but asymptomatic. we actually we didn't know the exact reason. So to summarize my presentation, the flow diverter seems to be feasible for giant intracranial aneurysm, but we do realize a learning curve exists. With our experience accumulated, less complication can be found. And for flow diverter is a big difference from other types of stent. The accurate measurement of the parent vessel and the flow diverter specification is very, very crucial, because the flow diverter deployment requires a very good vessel wall apposition. Otherwise, it would result in reoccurrence of the aneurysm or thrombus formation. Meanwhile, in some kinds of influences on the perforators and the branches should be noticed. Combined coil use seems to be helpful, even especially for aneurysm is a large sac and inflammatory aneurysmal wall. Last, modified peri-procedural management should be done, especially in this case. Thank you for attention.
Thank you very much, Professor